Well, thank you for joining us today. We have a three-part webinar for you that we're excited about. Just last week, President Trump announced this three-phased approach to opening back up America. And so we're starting to get a lot of questions from our clients, from employers, asking, what does that look like for my workplace? And really, the sessions that we have are actually I think the first one is very interesting. The second one's very interesting. The third one's really interesting because it's employee benefits. But we divided into kind of three parts. Part one is we're going to hear from Creagh Milford. Dr. Milford is a physician who you'll hear about in depth here in just a minute. And he's going to talk about what COVID-19 is. What do we know about it now that we didn't a month ago? What does that mean for our workplace? And I think that will be kind of some interesting information we can keep in the back of our mind as we work through the second part, which is the employment law considerations. And then the third part I'll be covering is the benefits perspective. So I'm joined today again with Dr. Creagh Milford. My partners, Charlie Plumb and Kirk Turner. And we're excited to be here. Please keep in mind, by the way, that we have the COVID-19 Resource Center on the McAfee Taft webpage, and we continue to post articles and video content there. If you've not signed up for it, please go to the website and sign up so that you make sure you get all the alerts that we have. So with that, I'm going to turn it over to Dr. Milford. And Creagh, tell us about your background and kind of who you are, and let's start there.
Sure. Thanks, Brandon. It's a pleasure to be with you guys today and an honor to be with your audience. So I'm an internal medicine doc by training, did my attending work and my clinical work for about 6 years almost at Mass General Hospital in Boston. Really, my focus has been on public policy, public health, as well as healthcare innovation, moving the last couple of years into the business side of healthcare. Presently, I serve as CMO, Chief Medical Officer for Healthcare Highways, which is both a network and a health insurance company in Oklahoma, Texas, and Louisiana. And we work with McAfee and Taft and many of your clients in a number of varieties and variety and capacities. And so we've been working with both our network clients and our health plan clients through the COVID crisis and helping them understand, much like you guys have, related to really the medical and health plan aspects of COVID and what to expect through this really unprecedented time.
And Dr. Milford, you were kind of one of some of our first discussions about COVID-19. You were thinking about, just to give the audience some perspective of kind of what you're thinking about. You're thinking about what does a health plan have to cover? Do we have to cover testing? Do we have to cover treatment? Should we? And I know you're a big advocate for telemedicine, and so we're going to talk about that later, but you're definitely someone that is forced to kind of think about where the puck is going and not where the puck currently is, right?
Yeah, I think it's been very interesting. I'm part of, like many companies, our company actually formed a crisis response team. And as such, I help with that committee comprised of our senior leadership to think about both our business and our customers. And like many businesses through the United States, we are faced to make dramatic changes in our business and our business model. But we're also delivering insurance, right? People are still seeking healthcare and seeking services. And fortunately, we don't have any COVID positive patients within our health plan, to your point. But we have a lot of questions that have come in, both from members and patients. What do I need to do? Where should I seek services? And where to get tested? As well as from providers as it relates to how to get reimbursed, how to think about changing their own practices to adapt in really a time of unprecedented social distancing. So we've had to face a number of different issues, some of which will be familiar to your audience, and others I think that are really more pertinent to the insurance industry, health insurance industry, around how to think about the other side of paying for and caring for all the patients that are affected and businesses affected by COVID.
So, Dr. Milford, we've had 6 weeks, 2 months, or something like that, where we've been nonstop news about COVID-19. What do we know for sure about COVID-19 now that we didn't necessarily when we first started hearing about it on the news?
Yeah, great question. We get this a lot, and there is a lot of news and headlines about it. So some of the facts are, first and foremost, this is an RNA virus. It really was found in bats, despite some of the popular headlines that you're reading out there. And coronaviruses, that class of viruses, are pretty widespread and common amongst bats and even other animals. And it's really infrequent that coronavirus in particular, or most viruses, jump or spread to humans. The last two examples of coronaviruses that did that were SARS, which you're hearing a lot of news coverage about, and MERS, which is the Middle Eastern variant of coronavirus. What's fascinating about this coronavirus, to your point of what we know about it, is that number one, it is more infectious. So the scientists call this the R naught, which really means that the R naught is 2.2 or thereabouts for this particular strain of coronavirus. And therefore, if a person's infected, two people around him or her are more likely or very likely to become infected. And that's relevant to how we think about the spread of the disease. If you look at influenza, it's the R naught generally somewhere less than one, meaning that only one individual would be infected as a result of that close proximity. The second thing that we've learned, which is super interesting, is that this virus, unlike many other viruses, has a long latent period where it's asymptomatic, where we can have people who are shedding the virus and COVID positive, if you will, but actually are asymptomatic, have no symptoms at all. And predominantly, we see this in younger, healthier people. And that actually is a concern for spreading the disease. And that asymptomatic period is up to 5 days or so. And then I think we've learned a lot over the last couple of months. Even myself and a lot of other physicians in the community, believed out of the early studies coming from Italy and China that people would be most affected if you had an underlying respiratory condition. We've really found that the latest studies, as of last week even, show that number one comorbidity for this disease is hypertension, followed by diabetes, and then followed by hyperlipidemia or high cholesterol, which is something we wouldn't have thought of even a few weeks ago. You would have likely put on that list asthma, COPD, underlying respiratory conditions, by virtue of the fact that this is really a cardiopulmonary disease phenomenon. And so that is, I think, unique, and we're learning more about being able to treat it as a result of that. The other final thing that we are learning is that this particular variant of coronavirus, COVID-19, is actually able to stick and last and be more durable on surfaces than really other potential viruses in the RNA family. Of course, sunlight and other things can degrade the RNA virus outer coating. But in this instance, we have found there was a great New England Journal article that was published on demonstrating that the virus can live on cardboard, for example, for a day, and plastic all the way up to 3 days, which has changed, I think, dramatically very simple things like how we all live our lives in terms of cleaning off groceries that have plastic bags surrounding the groceries, to more complex things related to businesses and the distribution of goods and services. That both applies to the healthcare industry. There's lots of plastics now involved with healthcare machines and all the rest, all the way to other businesses in the U.S. So I think that has been lessons that we've learned, and we continue to learn as time goes on.
And I hear a lot of comparisons between, you mentioned the flu, between this COVID-19 and the flu. How are they different?
So it's really the combination of those factors, the fact that it's more contagious, It has a latent period, meaning that it's asymptomatic, but you're still positive and shedding the virus. And it actually can last on different surfaces. That those three together really make this much, much more different than the flu. I have, like you, Brandon, a lot of people have come and said, well, this is just like the flu. I should just go get, infected. Uh, and what we found, which is striking, and what people are tracking in the news, is the mortality rate. Therefore, because of those three factors, and the fact that when it really is ingested and or inhaled, it actually is much more aggressive in terms of the clinical course of the patient, and that leads to higher mortality rates. The mortality rate in the United States has tracked as we've gone through both the numerator, which is the number of patients who are people who have died, and then the denominator, those that have been known to have coronavirus. We generally thought, even a month and a half ago, that the average mortality rate for this disease was somewhere around 2.2%. If you look today at the headlines and in the overall counts, it's actually more like 5%. If you compare that to the flu or many other viruses, the flu is less than 1% generally in terms of its mortality rate. So this particular coronavirus is certainly more deadly, and which is why you're hearing so many more people, really taking extraordinary precautions. We also have learned that really for the general population, you're hearing a lot of news that, I have coronavirus and my symptoms were rather mild. There's going to be 80% of the population that will fall into that category who are otherwise well and healthy. But then there's those that are really kind of above the age of 60. And in particular, if you're 80 to 85 and above, that are certainly at more high risk. And in particular, if you have underlying comorbidities or additional chronic conditions. And then your mortality rate jumps to 10 to 15%. In addition, the final thing I'd say that makes this different from the flu is unlike the flu, and we'll get to this if we talk about treatment, is that we don't have a vaccine, we don't have herd immunity, and we don't have really any really well-known ways of fighting this disease relative to other viral illnesses that we tackle, every day in the hospital setting.
You mentioned treatment, and I know when the first time I heard of COVID-19 or started paying attention, I started Googling treatment for coronavirus. I didn't know what a coronavirus was. I just knew this was one of those. And then I wanted to know, what do you do what treatment is there? What if any? And my understanding is there's none, but what looks promising?
Yeah, there's a lot of, the amazing piece of our scientific community right now is that if you look back to even the last SARS event, which was almost a decade ago, the ability for public-private partnerships and drug companies and all the rest to create solutions, vaccinations and antivirals particularly, took months to years. The use of data in terms of who's being infected, what receptors are really in play, which is we know much more about this particular coronavirus, COVID-19, that affects the ACE2 receptor, which is a receptor within the lungs. And as you look kind of across the public health setting for examples of where human beings successfully tackled, viruses, polio, influenza, both come to mind. And those are really solved through two main mechanisms. The first is what scientists or we call herd immunity, which means you get infected or exposed and you build up antibodies, and then you can pass those antibodies down through generations, both through your children and really through the spread of the population, that of those that are infected and build up antibodies and remain healthy thereafter. The second is the use of antivirals. There is a number of promising antivirals, some of which have been used 10 years ago, for the last incidence of SARS, and are showing some significant promise related to treating folks with COVID. And then you're hearing a lot of news related to hydrochloroquine and azithromycin, which is really drugs that we've used, or I've even used, for anti-malarial treatment, for those that we treat that have malaria. And so those medicines today have been proven to stint or curb most of the symptoms and the overall course of the disease, although not yet provide treatment or full protective immunity, which really would come through the use of either herd immunity or ultimately vaccination, which we think vaccination is still probably 18 months out. So you're seeing on the headlines a number of patients who are donating their plasma. What's fascinating to me is that since really the late 1800s, using plasma and distilling it and then giving it to the next person is a therapy of giving those antibodies to the next person who is infected, and then helping their immune system build up enough antibodies to fight and mount a response. What's interesting is that's really a one-to-one connection. So, Brandon, if you had COVID, got better from it, and then gave me your antibodies, kind of one-to-one, it doesn't create an entire societal response, if you will. So there's a lot of treatments underway. I actually hold out a lot of promise and hope that I think we're making, to my first point, much, much further progress than we ever have before through a lot of different unique public-private relationships. But it certainly, we still have many months to go for an ultimate vaccination or cure, if you will.
Let's shift to talking about implications here. So how has this impacted the healthcare system and the way we receive healthcare, and talk about implications, the different groups of people impacted, and what the implications for those groups might be?
I think that the really interesting piece to me is that how underprepared our country was for this, and any country for that matter, how quickly it hit, and how uh, how we had to really ramp up the use of PPE, which you now hear about all the time, personal protective equipment, masks, glove, gowns, etc. And I think that's a learning lesson for our country, for our government, for healthcare organizations. We've heard stories of different larger organizations now using their supply and shifting it across different hospitals that are more hard hit by COVID. Those are all lessons that, quite frankly, many of us that have been around for a long, long time have never experienced a pandemic as global and widespread as this. On the physician side, to your earlier point, we're seeing a lot of physicians who have really dramatically increased their use of telehealth across many different modalities in terms of treating patients. And I do think that on the consumer front, patients are going to similarly request it of us as physicians to provide telehealth as a more routine option in terms of ongoing routine care instead of going to see their doctor in person. On the hospital front, this has been really exposed, I think, a part of our really hospital and how they run in terms of performing a lot of surgeries, performing a lot of elective surgeries at that, and the resulting downstream economic impacts that it's having on those hospitals. In addition, patients who may have had an elective or even potentially non-elective procedure are pushing those off, which is we hear story after story of hospitals whose beds are half full, and I think the hospitals are learning how to cope in very different ways today. Everything from coping with specific COVID patients and the protocols around physicians entering the room and entering the floors of COVID patients, all the way to how they're generally responding to the change and shift of utilization of healthcare across their healthcare systems.
I heard the three phases announced last week, and it gets me excited because not because I'm not because I think it's right or wrong, but just the idea of the world starting to open back up again, and that's what we're going to talk about. We're going to shift to here in just a minute, is talking about the workplace and what this means for the workplace. What are your thoughts on the three phases, and then what society and employers might look like as we work through those three phases?
That's a great question. And I would say, I don't have all the answers, but our business, just like yours, is working on what does it look like now that President Trump and the administration have said that we're going to, uh, really move into a place of a reopening business. What's so interesting and timely is that the total number of cases really, it looks like, have plateaued as of today, which is Monday. And so that's great news. I think many of us are bracing for, and what you're seeing of those three phases is trying to create early signal to noise related to any potential second wave of reinfection by virtue of people uh, really going back to their normal course of life. From both kind of the health perspective and a business perspective, how we're thinking about it is first and foremost keeping employees safe. So thinking about what types of employees should be coming back and at what time frame, what intervals. We're thinking about taking temperatures in the workplace. If you have to take a temperature upon entering the workplace, we spent a lot of time thinking about IT equipment. How do we had, for our business, we had a call center. Those people are now virtual and their monitors and computers are at home. How do we bring those back in and clean them and quarantine them for a period of time to get them back up and running? And then, from our perspective, there's other more interesting questions around, well, who then of our business, there's really no one, I'm the CMO, but outside of that, for a traditional business, of having a person dedicated to doing all these tasks, to thinking about tracking all the temperatures for employees, for example, of your business. Uh, Second, we're thinking about keeping businesses safe. So how do you think about that? We've had questions of, do we need to wear masks in the workplace? We're supposed to wear them socially. Do we have to wear them in the workplace, particularly if I'm in a cubicle? And then how does that relate to doing my normal activities that I otherwise would do related to talking on the phone? Uh, our own business, we're thinking about a couple different uh, features of bringing people back to work, which is first, should you bring them back in different shifts? So what types of employees can you create team A and team B, and team A comes back on Monday, Wednesday, Friday, or half the day and half the day? Or can you bring back a third of your employee base, for example, in our business, over the course of a 2-week interval, so that, heaven forbid, if you have a positive COVID case, that you don't have to kind of go back and shut down that entire unit of your business. So we have a lot of open questions there. I would say we don't have all the answers, but we're working on them. And then I think that the longer term implications of both on our personal lives and our, society is that, we've got a lot of friends and family and colleagues across the country saying, hey, they're hesitant to go do the normal things that we all would do related to going to see a football game, going to see a basketball game. And so going out to dinner. So those types of social gatherings and events are really important to society, but also uh, put you at a little bit greater risk for coming in contact with someone who has COVID. And I think it remains to be seen how quickly those are in President Trump's phase 3, uh, how quickly those things come back online. And you really, even if they were to, how quickly people are accepting of really going back to those types of events. So I think those are the bigger questions. In healthcare, really, really interesting set of corollary questions to that, which are, for us to have patients being seen in the hospital or undergo surgery, you really want to ensure that they're COVID negative. You have to test. So all those tests that people talk about would have to be widely available to all those workers to test patients. And then also testing the immediate family members to ensure that they're not exposing that individual who might be coming into surgery. So I think there's still in the healthcare space many questions that remain to be seen. And in addition, the final point I would say on the three-phase approach, which I generally agree with, is that phase one does require for health systems and providers to really continue to keep a capacity for a potential surge, which creates questions around how you kind of plan for reopening if you really have to keep your PPE and your ORs and your bed capacity at certain levels. So those are all very interesting questions that I think people in big systems are still trying to grapple with today and through the course of this week and coming up as we continue to try to think about reopening.
It's been curious to me. So we've talked about the three phases, and we've all been hunkered down, staring at our spouses and playing board games and stuff. But when we go back to normal, what I guess, do the three phases, are they intended to help keep this from exploding again? In other words, it's always, if we don't have any treatment and we don't have a vaccine, and we all go back to our, somewhat of a normal way of life, it seems like we're going to have cases that increase again, right? And that's a question, actually. I'm curious if that's true. And so do the three phases help with that phenomenon?
They should. I mean, again, it's so interesting. I was listening this weekend, and hindsight's always 2020 in every business and in history, but we don't know what we don't know, and so I do think that this is the best approach to try to reopen. But we have to be sensitive to the fact that we are going to have, no matter what, we're going to have what I'm calling little hotspots of case counts that continue to increase. And in those areas, those geographies, we're going to have to pull back and continue to withhold. There's been so many people who have said, well, the death count in my particular state or city is so low. Why are we doing all this? And what's the point? And I just keep trying to remind people that it is actually because of these rather extraordinary measures that we've all taken, is because that we don't have the extraordinary numbers. In some areas we did, and we do, like New York, but in others, like we live in Dallas here, and it's not as bad, but predominantly because actions and steps have been taken. Once we loosen those, to your point, I think that's when we're going to have to all, both government, business, and people, society, be tolerant of, kind of the two steps forward, one back phenomenon. And I do think that that's going to be something we all live with through the immediate and, intermediate future.
Well, great job. Thanks so much. I'm thankful to you personally for doing this, and I know you're a very humble guy, but a very busy guy, and appreciate you joining us. So.